Right. Welcome, everybody. Thank you for joining us here today. Welcome to the rerun of Sonocyte's Behind the Scan webinar titled Diagnostic Shoulder Exams, Lateral Shoulder. This is the second in a four-part series about shoulder ultrasound. And if you'd like to check out the previous webinars in the series, you can go ahead and visit our webinars page on sonocyte.com. We'll be rerunning the third and fourth parts of the shoulder webinar series in January. We look forward to seeing you on January 9th for the posterior shoulder and on January 16th for the superior shoulder. And those will be at the same time as these reruns today. With that out of the way, we can get today's presentation started. My name is Chris Pennell, and I'll be moderating today's webinar. Before we begin, please be advised all attendees are muted. We'll conduct a Q&A session at the end of the presentation and demonstration, and you can type your questions into the Q&A box in the toolbar located at the bottom or the side of your screen, and we'll get to those questions at the end of the presentation. This webinar will be recorded and archived for future reference on our webinars page. Here with us today, we have Daniel Shelton. Daniel is the Director of Musculoskeletal Market Development for Fujifilm Sonocyte. Daniel has spent 19 years as a dedicated musculoskeletal sonographer, and 14 of those years have been here at Sonocyte. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. We'll go ahead and go ahead and start the recording now. Thank you so much for joining us.
All right, thank you, Chris, for that introduction. I want to welcome everybody again. This is the lateral shoulder. This is a running part of our four-part series. This is part 2. If you did not catch the anterior shoulder, I encourage you to go back through our webinar library and get caught up on the anterior shoulder and the associated artifacts with musculoskeletal ultrasound, such as anisotropic artifact or angle artifact. We'll discuss a little bit of that here, but it was more in depth in the first of the 4-part series. So with that said, a little bit of background about what we're going to be talking about today. There's a lot going on in the lateral shoulder, and we're going to cover these slides really quickly. And then we're going to spend the majority of our time on the live demo. And then hopefully a heavy amount of time on the Q&A with your questions and maybe anything that you want clarified in the live demo would be best addressed in the Q&A. So have those questions ready, have them typed out in the chat portal or the Q&A portal for Chris to address. He'll tally those up and we'll run them through in the Q&A portion. But you're going to see a lot of diagrams. You're going to see a lot of anatomy, ultrasound images depicted in here. I'm not going to read from the slides. I'm going to breeze through these slides as quickly as I know how to, but just know that this is recorded and you can go back through the recording and use these and pause these videos as a diagram for you to scan along. I encourage that. You go through these slides, you hit the pause button, and you try to achieve the scanning targets that are discussed in each slide, and that will help be a very nice scan along. So let's go ahead without any further ado, and you'll notice I have an anatomy image up here depicted already. And this is the shoulder not in anatomical position. This is the modified Crass position, and it's very important to scanning the lateral shoulder. In the anatomical position, we're slightly externally rotated, and you'll see that the greater tuberosity would typically be sitting out here laterally underneath the acromion for the most part. So what we have to do to bring out these cuff structures like the supraspinatus and infraspinatus away from the acromion is we have to rotate the shoulder this way. And we just tell people to either place their palm in their back pocket. The real key here is to not let there be much of a gap between the elbow and the rib cage. So what we're doing is a couple of things, and we'll do this in the live demonstration, is we've taken the greater tuberosity from a lateral superficial structure, okay, to this anterior and deeper structure. And we did that by internally rotating, then dragging the elbow back posteriorly, which is not super evident here. So when we rotate the model, both anatomical model and the photograph, we see how far back this elbow goes. If your patient's not able to do that, it's okay. Start in a fairly neutral, just arm slightly internally rotated and pull the elbow back maybe to the outside of their thigh and just see what kind of range of motion you can get away with. But look at the stretching that's occurred on the supraspinatus anteriorly. The infraspinatus follows as it overlaps the supraspinatus by a third. Teres minor follows much more inferiorly, and we'll talk about those, especially in the live scan. But there is a twisting anteriorly and a dropping of the greater tuberosity inferiorly. So we've taken the greater tuberosity from an anatomical position, which would face us here, and we've wrapped it anteriorly and dropped it inferiorly, and that's going to dramatically change where our transducer would be located. If you looked at a traditional anatomy diagram, I think you would assume that your transducer would be placed very lateral for a rotator cuff exam. And just know from a patient positioning standpoint, any surface landmarks have now changed from where we put our probe. So we're not going to be focused on the lateral anatomical shoulder. We're looking at lateral structures, but we're going to have the probe very anterior. Anytime I'm evaluating major tendons, I start in a short axis. So we're going to go straight into the short axis transducer placement for the supraspinatus, which is here. And we can see this rounded oval of the supraspinatus. It's cut in half. This is your sagittal MRI equivalent. Here's the coracoid process as a landmark. So the medial side of the transducer, screen right, is the patient's medial side, just under the fingers of this photo, and that's where the coracoid is going to be. And then what you're going to do is just windshield wiper over until you see the humeral head typically. And if the humeral head is not sharp and crisp, the rest of these structures are not going to look very good either. Here's that familiar biceps tendon. If you do not see the biceps tendon, don't move forward with this exam. We need to see the biceps tendon if it's there. If they're post-operative and had a tenodesis or something like that, keep that in mind. But we're really looking for the biceps because its next lateral landmark here is the supraspinatus. There are other structures that we'll talk about toward the end of the slides between the biceps and the supraspinatus. But for now, let's focus on this leading edge of the supraspinatus. That's where all the pathology happens for the most part. Infraspinatus won't be so heavy this slide deck, but we will discuss it a little bit. But we've cut the rotator cuff in half, and we're looking down the fibers as a sagittal MRI equivalent. Now let's colorize these structures, and I've got part of the transducer on the coracoid and the other part of the transducer on the acromion process, and this makes up our transducer placement for the proximal supraspinatus. So this is where the musculotendinous junction is, and we can see the central tendon of the supraspinatus and the muscle fibers following of the very proximal edge of what we consider to be something to look at. But here's your coracoacromial ligament. If it's dipping or sagging, we've got volume loss, and that's something to look for here. This is also a good position to do wagging of the elbow for any adhesions that may occur in the subacromial bursa to that coracoacromial ligament. We can look at that in the live scan. Again, leading edge of the supraspinatus is our focus for these slides. We'll get to the rest of the interval structures shortly, but supraspinatus and biceps tendon relationship is really important. It will not change as we fan this transducer distally down the greater tuberosity, and we're going to look for the shape of this humeral head to change. So unless you have a rounded humeral head, I don't want you to advance the transducer, okay? So we've advanced the transducer to this new white location here. You can see this big dot, just like in our last set of slides, and in the wrist is going to represent the left side of the screen. This thumb orientation marker in the transducer is the left side of the screen. So here we have the humeral head. It's nice and bright. Supraspinatus has this big oval leading edge appearance, and we're really just going to be focusing right here on the leading edge of the supraspinatus and transverse. Here's that biceps tendon for reference. As we fan distally, that's where a lot of things change. And as we go distally, we leave I'm going to go back to the humeral head. Let's look at these changes. We have the humeral head, which is rounded. We've not hit the greater tuberosity yet. And I see the articular hyaline cartilage here, and it's also capped here in blue in the illustration. But as I go further distal and drag the transducer, relatively speaking, towards the floor because of the arm's rotation, watch the shape of the humeral head change. Cortical landmarks are number one in MSK because soft tissue changes so frequently, and that's what we're here to look at. Follow your bony landmark first. And what I'm going to do after I find a nice sharp cortex is I'm just panning, dragging like a paintbrush, the transducer distally towards that ball shape of the shoulder, and we end up with this apex here, this bony peak of the anterior and the middle facets of the greater tuberosity. Here's the biceps tendon for reference. It's not so prominent here because it's anisotropic. It has the angle artifact. It's not the focus of our exam right now. We're really focusing on making sure we don't have any anisotropy or angle artifact across the footprint of the supraspinatus tendon primarily. Infraspinatus tendon will be kind of a collateral concern at this point, but we're really focusing on these fibers here. You can see this dark rim here. We want to wag and tilt the transducer and try to get rid of this anisotropic artifact. Also, compression is very useful here. If you suspect a tear, apply transducer pressure and see if you can't get the subacromial surface to collapse into the supraspinatus. It's at this point that the supraspinatus actually has a very unique relationship with the infraspinatus, and I'm going to go with the next slide to illustrate that. So here we are. This is a 3D CT on the greater tuberosity facets under the Chromium process, and we're really focusing here on the anterior facet of the greater tuberosity, or the superior facet, I should say. At that superior facet surface, we have primarily supraspinatus. We will have about 1/3 of the tendon fibers of the infraspinatus overlap the supraspinatus at this point, and you just want to sweep and scan proximally distally until you see this relationship. And as we scan more proximally, you'll actually see this diagonal line show up between the infraspinatus and supraspinatus, and we're going to show that in the live demo. We want to maintain this relationship to the biceps as much as we can, but that relationship leaves a little bit as we're in the interval, and we start to see this gapping between the biceps and supraspinatus. And we'll talk about the interval after the main supraspinatus slides, but just be aware of this cortical landmark, this apex of the greater tuberosity, sometimes called the anterior facet or superior facet, as illustrated here by Dr. John Jacobson in the Fundamentals of Musculoskeletal Ultrasound book. It's in its 3rd edition. I encourage everybody to give that a read. It is it's the best handheld reference, non-hardback, easy to travel with. It's a great read. It's not your typical radiology book, and I think you'll enjoy it. So this is a great illustration. It's just depicting that point with all the other stuff just decluttered, like the interval and the deltoid and its septations and things. It's just really simplified, so I enjoyed that illustration a lot. And then overlying all of these structures, we have the subacromial subdeltoid bursa and its layers, and there are many layers. Going to long axis now. We've rotated the probe 90 degrees to a longitudinal plane to the supraspinatus. This is a coronal body plane, and then we're going to be panning the probe lateral and medial. We're looking at the humeral head to be rounded and the greater tuberosity to have this kind of parrot's beak. As I mentioned, the difference between the subscapularis and the supraspinatus is cortical landmark that I discussed last week at the anterior shoulder demo was that a subscapularis, while it looks very similar, has a very flat beak. So it's a bird's beak. This is a parrot's beak. It has a hooked bill. If you want to get nerdy about how you remember these things, that's one way to do it. But it also identifies the actual footprint of the predominant supraspinatus. Here's some angle artifact. We would tilt the probe and get that feathered out. It's anisotropic artifact, and I think if we just aim the beam back into the footprint, you'd see that clear right up. Let's go into how to scan that. Start at where the round ball of the shoulder meets the chest wall. There's this divot, and what you're not seeing back here is my fingers are placed firmly in that divot of the shoulder where the chest wall meets the remainder of this ball shape of the shoulder. Set your transducer right on the outer ball shape, but what you want to do is just fan that transducer towards the fingers. And as you do that, you're going to come across this very deep humeral head, and the humeral head is going to have this irregular contour, but it should be smooth. You're going to see this arc shape with the fibers in it. That's the biceps tendon proximally that we scanned on the anterior shoulder. That is our landmark, because in long axis, this biceps tendon is parallel to the supraspinatus tendon laterally. So as we pan this transducer laterally, we will immediately see the supraspinatus. So until we see the biceps tendon anteriorly, you will not be confident that you've evaluated the anterior margin of the supraspinatus. It's that has the most pathology. If you're not seeing this and you're not able to get this arc shape of the biceps tendon, take a look at your patient's elbow. We'll do this in the live scan. But if it's wagged too far out like a chicken wing, you're not going to get it. You need to bring the elbow towards the spine, and that will bring and externally rotate out this rotator cuff interval, which is where the biceps is, and we will get this landmark really nicely. So after that, we're going to pan the transducer about 1 centimeter lateral, and you'll see that the bony landmark has changed dramatically, more like that MRI contour slide that we looked at. So here we are just lateral. We're on the very peak of that ball shape of the skin surface, if you can palpate that on your patient. We have the rounded humeral head and greater tuberosity. Greater tuberosity is in profile, and it's got this nice curve to it, like a ski jump, versus laterally. As we pan more and more laterally, you'll see it flatten out. If it flattens out like this, just be aware most of these fibers are actually infraspinatus coming in from the posterior margin, and be aware of any contour changes of the greater tuberosity. So there's a big difference in going from here to here and how that is shaped, because as we see this greater tuberosity flatten out, it means you've gone so far posterior, you're leaving the fibers of the predominant supraspinatus, and right in here, which should be illustrated but it's not, you start to see this overlapping wedge of anisotropic artifacts. Sometimes don't confuse that for a tear or pathology. That's infraspinatus. So let's move even further anterior from the supraspinatus. So here we just got done evaluating this tendon in both short axis and long axis, and let's find out what those parts were that were surrounding the biceps tendon. From the coracoid process, we have this overlying ligament that has many fibers going many different directions. Some go over the biceps groove, some go under the supraspinatus, some go over the supraspinatus, and that's the coracohumeral ligament. This acts as a stabilizing sling for the biceps. So it's not all up to the biceps groove to keep it from dislocating into the subscap. A lot of the strength, in fact, more often relies on this coracohumeral ligament in conjunction with the transverse humeral ligament, which is here. It's very broad and is more of an extension of the anterior subscapularis fibers. So anterior subscapularis, which we evaluated last week, shares fibers and jumps over the biceps groove to create mostly that transverse humeral ligament, which blends in with the coracohumeral ligament. And these ligaments are the things that stabilize the biceps. So other things that may be pain generators or sources of instability in the shoulder, and various other things to look for. Don't forget about these ligaments surrounding the biceps. So we're going to climb, actually we're going to slice this and get more of a cross-sectional view of what we're looking at. So we just got done evaluating the anterior supraspinatus and its cross-section. Surrounding like a yin-yang and like a hammock on each side bordering the biceps. The biceps pierces between this relationship of that superior glenohumeral ligament, which is acting like a hammock, and the coracohumeral ligament, which is subtracted quite a bit of transparency here, but it is acting as this big broad bridge up and over the biceps, and they taper together along with the joint capsule to wrap around the biceps. And that's what keeps the biceps intra-articular, is this joint capsule sling that is a part of this complex. So when you do a biceps tendon injection that's too proximal, you're going to end up dumping it into the joint. And that's why you want to go distal in the biceps groove when you do a biceps sheath injection, so that the remainder of your injection does not end up in the joint. If you have a large joint effusion of the glenohumeral joint, it's right here at this window that it will outpour into the biceps sheath. So if you see a huge effusion in the biceps sheath, you can almost 100%, I think it's 90-something% by Jacobson, rely on there being some sort of rotator cuff tear that let fluid out into that articulation of the biceps. Let's take a look at how that images. So here we have the biceps tendon as this oval over the humeral head that is pretty rounded. It's irregular in shape because the biceps groove is kind of tapering away and we're about to hit the humeral head laterally. But the CHL and the SGHL are like this sling around the biceps. And we'll focus on that in the live demo. But the graphics are here for your future reference so that we don't spend too much time. One more thing before we go to the live demo, we have the subacromial subdeltoid bursal interface, and we'll be doing this predominantly in the live demo. But just know, in a modified CRAS position, you can still see these layers really nicely. So this is all supraspinatus primarily from here to here, right where my mouse is starting and stopping. And then we have these other little soft tissue layers, and there are a lot. I think there's something like 7 layers when you get to the peritoneum of the supraspinatus, peribursal fat, the actual interface where the two structures are gliding on each other of the subacromial bursal potential space. And then you have the subacromial fat of the subdeltoid fascia, and then you have the peritoneum and subdeltoid fascia of the deltoid. So there's a lot of layers here to get your needle lost. So we're going to apply some dynamic maneuvering to make the interface of this as clear and easy to see as possible. And then when you go into do your abduction maneuvers for impingement, it's going to be a relatively anatomical plane. And that's why we see the acromion here. We see the greater tuberosity so close in relation, is that we're not going to stay in the modified CRAS position. We're going to go to anatomical position, relatively speaking, and we're going to abduct and watch this glide. But look at the teardrop. Look at the dependent recess of the subacromial subdeltoid bursa laterally. That that peribursal fat, that white interface of the subdeltoid fascia, it's these layers that combine that have this redundant fold over the greater tuberosity laterally and create this really nice pouch for free fluid to exist. And when we internally and externally rotate, abduct, and internally rotate and strain, like the modified CRAS position, this big redundant recess unfolds and allows us to have that range of motion. But it also fills with free fluid in the case of either bursitis or if you have some sort of cuff tear that goes from articular to bursal surface. And we'll talk about that in the live scan. But it's just a couple words about the subacromial bursa and its interface, and I think it's just better depicted in the live scanning. So what I'm going to do is go ahead and get set up for the live demonstration and kick it over to that. After the live demo, it will be time to answer your questions. So have those ready. I know the slides were really fast, but we're going to predominantly spend the rest of the time in live scan so that those points can be driven home with a more dynamic study. Don't forget to use these slides for future guidance on what those tissue layers are. 1 second while I switch over. So just like on the anterior shoulder, we started with the patient facing the machine. I was standing behind the patient. That's really how I like to scan shoulders because I get to rest my palm up here. And the majority of all your pathology will take place within roughly 1 inch of the acromion anyway. So we're not traveling far away from the acromion, and that's why I like to rest my hand up there. So I'll be selecting the linear 15 megahertz transducer on the Sonosite PX. I've got my system where I want it to be. I've tilted things where I would like it to be, and all my controls are facing me nicely here. I'm going to keep the left side of the screen to the patient's right, or lateral here. And to start out with the supraspinatus exam, just in case your patient is not able to do the full modified CRAS, I like to just take a spot peek first before we start stretching them into various positions. So I'm just going to start with the probe over the acromion and out lateral. And here in this view, you're going to see a lot of things such as the subacromial bursa. You're going to be seeing the full volume of the supraspinatus in many cases. And it's just not necessary to go ahead and stretch the tendon and do any damage to something that may just be hanging on by a thread. So what I see already is very nice is, let me pull my arrow out. I see full volume of the rotator cuff. I'm going to bring my depth a little bit more shallow. And I see a nice smooth greater tuberosity. So proceeding forward is probably not super risky with doing a modified CRAS position. So I've done just kind of this quick survey of volume, and I'll go short axis as well, and just make sure that we're not suspecting any big major tear. We're going to be looking for subtle pathology here, in this case a normal exam. Here's our biceps here as our anterior landmark, and then here we have our anterior supraspinatus. So before you just look at the book or watch the video and decide that all your patients have to be stretched into that maximum level of modified CRAS and putting any stress on the tendon, just keep in mind you can see a whole lot of anatomy just without stressing your patient's positioning. So I'm going to add a bit more gel here, and with that gel standoff, it's going to allow me to do a nice subacromial view without collapsing the bursa. So while I'm here and not stressing the patient, let's just do a quick subacromial exam. And what I'm going to have our patient do is just slowly internally and externally rotate and wag the elbow a little bit. There we go. And then what I'm looking at is this bursal interface. You can see the hypoechoic line between those two layers of peribursal fat, subdeltoid fascia here superficially, peritoneum and peribursal fat of the supraspinatus. You can relax. And then zooming in is a good idea when doing these, unless you have a higher frequency transducer, which we can get to after we do the basic exam. And I'm just going to go ahead and zoom in on these layers. And then we'll do just very subtle internal and external rotation and watch those layers show themselves. So in a normal subacromial subdeltoid bursa, we should just see this very, very thin line. And then if you're just eyeballing how thick should a subacromial bursa be, let's just relax. I'm going to come up here to the hyaline cartilage of the humeral head here, and I should be able to eyeball that the subacromial bursa is not thicker than the articular hyaline cartilage. If it starts to get any thicker, it's time to pull the calipers out and measure whether or not you have a suspected subacromial bursitis. And there's a lot of published findings on that thickness, and just use your clinical impression. Does it compress? Is it effused, or is it just synovitis? Put your color power Doppler on and see if it's inflamed, or maybe something else is going on in the bursa. So that's one way to do a subacromial evaluation with internal and external rotation. I'm going to hit 2D to escape my zoom, and now I'm going to go long axis to the supraspinatus, and we'll do the subacromial impingement. So if you've ever been frustrated by this view, find your AC joint first, which we'll get to here in 2 more webinars, and go laterally on the acromion process here. From this point right here, what I just want you to do is point the lateral side of the probe anterior while pivoting and keeping the proximal side of the probe on the acromion. So I'm just going to windshield wiper anteriorly, keeping those 2 structures in view. We're relatively internally rotated in a neutral plane. And the reason I say that is our patient's hand is in her lap, and we're not out here in anatomical position. So when we're in anatomical position and the palm is forward, the greater tuberosity is extremely lateral, and we see what we see in the anatomy books. But right now we're seeing our patient's positions internally rotated. That's really important when it comes to doing any rotator cuff or any shoulder exam, is which position is the arm in. And now I'm going to have our patient not only just abduct, but abduct a little bit anteriorly, and we're going to be watching that greater tuberosity glide and clear the acromion process. Now, one tip while scanning this, if you've ever been frustrated by doing this, is as they abduct, notice the deltoid is starting to contract. And when the deltoid contracts, it can bump your transducer. So you'll notice all the weight of my probe is right here on the acromion, and I'm relatively floating the lateral side of the probe out here, letting the rest of the arm come up to the transducer. But I can see this interface nicely. While that provides a really nice consistent scanning surface, it also helps me know with confidence that I'm not collapsing the bursal interface with the weight of my transducer. So I can come out here laterally, just relax, and I can get a beautiful subacromial shot, but I fell off the acromion, and now I'm collapsing any bursitis I may have, or if it's simply effused, you're going to miss that. And if our patient abducts again, go ahead and abduct. That deltoid contraction is going to bump my transducer sometimes off axis, and it makes it very hard to scan. So those are my scanning tips for a subdeltoid bursal view there. In the Q&A portal, if you have questions about injections and where that needle should go, save those for the Q&A at the end. So from that subacromial exam and that non-invasive rotator cuff sweep, it's time to go ahead and stretch the rotator cuff tendon of the supraspinatus. And what I'm going to have our patient do is go into modified CRAS, which is the palm in the back pocket. If your stool doesn't have a backrest, that's a plus. If they do, sometimes they just have to scoot to the front of the stool. But if your patient's comfortable in this position, it's going to be just fine. Actually, I'm going to have you scoot up just a touch. There we go. And the reason for that is we're going to be moving the elbow just a little bit, and we want that free room back here. In modified CRAS, it's really important not to chicken wing out here. If you can get an arm through here, that's bad. If you can come up here and see that gap has closed quite a bit, it's going to bring the rotator cuff structures lateral, and when we're internally rotated, when we chicken wing out like that, the cuff structures go in and under the coracoid process, so I'm not able to see them. So you have to externally rotate the shoulder in this position. Most people like to just go ahead and plop the probe onto long axis and just get right to the point. Well, that's fun. That's okay. We're here to learn the scanning techniques of how to do this fairly thorough. And I'm going to go short axis first. So remember the anatomy diagram, we've pulled the structures anteriorly and inferiorly. I'm going to take this slice right here across that anterior humeral head, putting the medial side of the probe towards the chest wall, almost touching it completely. In fact, in this case, I am. I'm going to bring my depth down just a touch so that I can see that biceps. I'm going to check the gain on our webinar and soften that up just a touch real quick before we really get going. There we go. I kind of like that for what's being broadcasted. Let's bring our arrow back up and start pointing some things out. If I'm fanning the medial side of the probe over to a coracoid, it's this big prominence here. I'm going to fall off into the biceps tendon here. So I've located the biceps anteriorly. And then as I move laterally, I can see the anterior margin of the supraspinatus that we identified earlier here. Really nice. And then I'm going to keep traveling posteriorly until I see that that tapering edge between the musculotendinous junction and the infraspinatus, which will be this diagonal little line right here between the two over the articular hyaline cartilage level. As we go out more distally, follow the anterior part of the supraspinatus only, and make sure you keep the biceps tendon in view. Okay, so we're going to follow the biceps and the anterior margin of the supraspinatus first. Remember, the cortex needs to be nice and bright for this view. I need to see articular hyaline cartilage also. And what I'm going to do is just pull the probe almost towards the floor obliquely, and I need to see the cortex change shape. See the tendon, the overlying tendon's also changing direction. And I need to drop the handle of the probe, drop the handle of the probe, and I'm just walking down the humerus greater tuberosity. Did you see the transducer tilt as I pivoted distally? So let's do that again. We're going to go to the articular hyaline cartilage level. I'm going to go distal. You'll see the tendon disappear. I need to drop the handle back into the tendon. Go distal, see the tendon disappear, drop the handle back into the tendon. You're going to keep walking that down. We did something really similar in the carpal tunnel webinar when it came to all the anisotropic connective tissue artifacts that we had within the tunnel. Here's our biceps anteriorly to make sure that we're not losing our spot, our lighthouse. And then you can see that anterior or superior facet right here, as it's called, of the greater tuberosity, that bony apex we saw in the anatomical diagram. And you can see the infraspinatus back here, jumping over about a third of the supraspinatus's posterior margin here. So we're going to sweep up and down that footprint right here, and we're going to just be evaluating that leafy, feathery edge of the supraspinatus, and using sometimes anisotropic artifact to our advantage. Healthy tendon will turn dark. Okay, old scars, old dense collagen backfill of scar will not turn dark, and it will remain echogenic as you sweep the probe through. So what I'm doing is I'm just kind of panning through the tendon, and as you see me cause the anisotropic artifact, I'm just tilting the transducer back and forth through the artifact, making sure that whole tendon fills and the whole tendon gets dark. I'm going distally again, making sure the whole tendon fills and the whole tendon gets dark. And I'm going distally all the way to the very edge to make sure the whole thing is remaining nice and, well, anisotropic where it helps us. Maintaining our anterior biceps here, going through the interval. That would be me scanning through a short axis supraspinatus. Now what I'm going to do is come back to the articular hyaline level here. I'm going to tuck my transducer towards the chest wall, and I have the biceps tendon here in the middle of the image. And I'm going to spin the probe. I'm going to put the left side of the screen towards the floor or the patient's right. And what this does is just keeps us in line with a traditional MRI. I know not everybody on the call today is reading MRIs or trying to keep things correlated to an MR, but I'm gonna keep that there for consistency with some of our other material. So look how anterior and medial I am. I'm almost laying the transducer up against that chest crease, okay? And I'm maintaining a 90-degree perpendicularity to the biceps tendon, and then you can see the back half of what would be the humeral head. Now I'm going to follow this arc of the biceps. So this is distal, and you can use the anisotropic artifact and see that familiar structure that we looked at last week. Check it out. Biceps tendon climbing intra-articular here. Okay, so there's the intra-articular biceps as it's traveling down, and some people we can actually see it tapering into that superior glenoid tubercle with the superior labrum, but we're not going to focus on that just now. Let's follow the biceps as our landmark. Okay, so now I'm going to take this orientation here laterally, and I'm going to drag the transducer laterally because it's in this, like we talked about in the PowerPoint, the biceps runs parallel with the supraspinatus. Okay, so I'm just going to drag the transducer laterally, about a centimeter really is all. And there I can see the supraspinatus, just like we saw on the slides. Another scanning pearl here is if you're in a true long axis to the supraspinatus, your superficial fibers here, the deltoid, that anterior deltoid will also be in long axis. So take a look at that as just something that you can do to check your work. If you have nice long axis deltoid fibers in this position, not all of the positions get you that, but it's kind of a neat way to check your work here. So we're going to follow the supraspinatus fibers distally until they insert on the enthesis of the greater tuberosity. Let's cause an anisotropic artifact. So if I don't tilt the transducer at all, I get this wedge. And this is not pathology. This is healthy tendon insertion. See how the greater tuberosity is smooth? If it were jagged, like somebody had taken a bite out of it, if I saw a pull lesion, I'd be really suspect of this dark area, but it's smooth. Not only is it smooth, I don't see an overlying volume loss. So this tendon is occupying this space. If it stops occupying the space, like if this tears and retracts back, something has to fill that void. And what fills that void is the overlying subacromial subdeltoid bursa. So when that happens, we get this big dip. We no longer get this parrot's beak looking bill, and we get this big flattened supraspinatus tendon. And a lot of times the deltoid will just sit on the greater tuberosity. So this I'm already suspecting to be artifact. And watch me angle the transducer this way. And when I angle the transducer back into the footprint, you see all that tendon fill in. And this is really important that you scan posteriorly to the flattening of the greater tuberosity and anteriorly to the curvature of the anterior greater tuberosity, because that's where the tears happen. And I'm going to check my work again as I went to the anterior greater tuberosity. I'm going to watch the greater tuberosity fall, and that's how you know you're going to enter the biceps groove, basically. But I'm going to follow this part right here where tuberosity meets humeral head, and we should see that arc shape of the biceps as I go more anterior there. So there's our anterior marker, our reference point, our lighthouse to make sure that we've evaluated the anterior supraspinatus. So we did short axis, we did long axis. Make sure you're letting up on pressure so that you're not collapsing any pathology. That's also very important. When I'm doing these and I suspect a big tear or even a subtle tear, if I see something that looks like it may collapse, what I'm doing is I'm just going to let up pressure, and I can see where the gel was on the shoulder, and or where it's not, because my probe was pressing down, and I put down a bead of gel right on that square. And then I'm laying my finger down underneath the transducer surface to act as like a stilt, so that I can lay the probe into the gel first and get this really, really pretty view of the supraspinatus without compression. So see how the deltoid is not compressed, the subacromial subdeltoid bursa is not compressed, and if I had any suspect of any tears here, I would not be collapsing that useful pathology either. So just a little scanning tip that you can kind of pick up here and there. That one has helped me a lot along the way. Go ahead and relax. I'm sure our model's very happy to relax at that point. That concludes that supraspinatus exam. I'm just going to move to the rotator cuff interval now. So I'm going to have our patient just hang her arm out to the side and the arm slightly externally rotated. And then I'm going to place the transducer at the acromion first. And there where I see the acromion drop off to the humeral head, here, I'm going to follow the biceps tendon. So anterior slightly, there we go. Now when you see the biceps tendon is suspended up in the air, or not in the air, into this connective tissue, use the anisotropic artifact to your advantage. First we're going to zoom, and because we have the convenience of 19 megahertz, we're going to be checking out the rotator cuff interval at a high frequency. So I like where my zoom box is, so I'm just going to hit zoom again. That was easy. Okay, so here I am. I'm going to bring my arrow back up. Here's the biceps tendon right in the interval, and here we have the superior glenohumeral ligament, just like the anatomy diagram showed. Okay, we see subscap fibers way down here, superior glenohumeral ligament suspending the biceps like a hammock, tapering. There's some joint capsule in here that we don't see. And then here's the coracohumeral ligament complex, and it's quite the large ligament. Basically, you can see with very little toggling of the transducer, I'm going to follow, using this angle artifact to my advantage, I'm going to follow this stripe above the biceps to the anterior footprint of the supraspinatus here. Okay, and then I'm also going to be following some of those fibers to the superficial margin of the supraspinatus too. So these fibers really envelop the anterior supraspinatus here like a sling. A lot of the underneath fibers will even be traceable proximally to another structure that's a little bit more detailed, and we can cover in the Q&A, but we won't cover now, or I'll get way off topic. But back to the biceps and the superior, or the coracohumeral ligament. That's pretty much it. So once you fell off of the acromion, look for that humeral head, then look for the biceps tendon. You're not going to see articular hyaline cartilage under here very well, and you're going to be seeing a ligamentous structure, and like I think this looks like a yin-yang, this sling around the biceps. There's clearly this directionality enveloping top and bottom of the biceps. This is your rotator cuff interval. So by definition, we have subscap here, we have the superior glenohumeral ligament here, and then we're going to see this sling of this complex of that coracohumeral ligament dragging over to the supraspinatus here. And then if we see any anterior disruptions on the supraspinatus, we're always going to be highly suspect that this coracohumeral ligament may also be involved. There's a few other dynamic maneuvers that we can do
putting those ligaments into long axis and internally and externally rotating and stretching these ligaments. But those are things that they need to correlate with your clinical reason for why they're there, and they don't really fall under the basic exam. But hopefully this helps kind of demystify. It did for me when I learned about the rotator cuff interval. Let me zoom out. I was always pretty good at getting this view, the anterior supraspinatus. I was always really good at getting the subscapularis, and I was always really good at getting the biceps to look really, really cool floating between the two. But I knew there was just something here and there was something here in my early days of learning rotator cuff ultrasound. I never identified it. I knew there was a normal space here and a normal space here of connective tissue that I was never taught super early on that these were ligaments acting as a sling complex, and that they actually are responsible for a lot of the bicep stability in the groove. And it takes a lot of pressure off that transverse humeral ligament. So from a body mechanics standpoint, this is really the structure responsible for a lot of your bicep stability. So with that, we've covered our supraspinatus in depth, and I feel like we've gone through the rotator cuff interval and its little complex pretty in depth. And we also did some subacromial subdeltoid bursa scanning. So I think at this point we could turn it over back to Chris, and if Chris could let me know if there's any questions in the chat portal. I think we'll go from there and answer your questions live.
All right, as Daniel said, that was the end of the recording there. So if anybody has any questions, feel free to type them into the Q&A box, either at the bottom or the side of your screen. We will have Daniel here live answering your questions. There he is. And yeah, Daniel, we're waiting for questions. Is there anything else that you'd like to kind of go over, kind of any updates or anything like that for this part of the shoulder?
Well, making sure my audio is coming across. We're still good, Chris?
Yep, sounds
Okay.
good.
As far as updates go, there have been some system updates. So talk to your Sonosite sales rep about future released software upgrades for the Sonosite PX, also for the LX, and we've also released the newly released Sonosite ST, which is our upright touchscreen machine. So if you get a chance to reach out to a sales rep, they will be happy to send you information on that. But as we mentioned earlier, we are here to scan live with any of your comments. If we need to be more detailed or answer any questions while we've got everything live, this is your time. So feel free to jump into that chat portal and we'll get your questions taken care of.
Yeah,
I like to just kind of keep.
Looks like we have one already. Yeah, so we have, says, last week we saw a short axis biceps tendon deep to the transverse humeral ligament. Today we saw the biceps in the sling while looking at the RC interval. Would you be able to show both views of the biceps tendon? In other words, how far do you need to move the transducer to see the biceps in those two views? And could you demonstrate on the model?
Yeah, that's a great question. So when they're neutral like this, I start up at the acromion, right up top. So we've got the acromion screen upper left. Get our arrow up here. There we go. Actually, arrow. Okay. So screen upper left, we got the acromion. I always tell everybody to start with your bony landmarks. So right after that, screen right, we can see the coracoids. We're going to drop down into the rotator cuff. At this point right here, we see humeral head. And as we sit anteriorly, and this is really without stressing the shoulder. You know, I don't see any point in really putting our patient into a lot of positions that they don't need to be until we see that the obvious stuff is okay. So if I see a nice bicep sitting in the interval, I go back as proximal as I start to get a shadow, typically of the coracoid in a neutral position like this. And when I get that shadow, it's okay. I could even go long axis on this. That would be okay. And you could use the anisotropy as the biceps tendon dives into the joint. If we lost the anisotropy as the biceps dives into the superior humeral glenoid tubercle, if we lost the anisotropy, I would want to verify that with the other shoulder and make sure it's not just normal for our patient today. But you can use the anisotropic artifact that we're seeing right there diving into the superior labrum. So how far proximal can you go? It really depends on your patient's body habitus a lot of times, and sometimes even putting it into a little bit of stress helps, but not much. So we might just modify CRAS just a little bit. But if you're looking for that biceps pathology anyways, there's really no there's no reason to over stress at this point if you can just see everything with ultrasound. So here we are. We've rotated the ball of the humeral head more anterior. The biceps groove is now right up against the chest wall. And that's what makes this exam nearly impossible to do when it's in a modified CRAS. So we're going to have her just slowly relax and find the point at which that biceps climbs out from the coracoid shadow. So I'm going to go just north of the coracoid shadow and have her slowly relax. And that should bring that anisotropy into view. There we go. So you can see that nice shadow dropping down into that superior glenoid tubercle down here. And then as far as the two views go, we're going to go short axis in the rotator cuff interval where we see the biceps kind of suspended right here. And I'm going to remove the arrow, and we're going to show this in dual screen. So this is at the interval. So we see a nice, healthy, intact biceps at the interval level. And I'm going to hit screen right, and we'll just chase that biceps down the groove, have her just rest and relax. And it is nice to show that we have an intact biceps sitting both in the groove and at the interval level right there. So screen left is lateral. So I've got the patient's right side and the left side of the screen. I like to go ahead and save that. We can also see the color of the ascending branch of that lateral circumflex humeral artery sitting in the lateral groove. So we just want to verify that is not a tenosynovitis or anything like that, and that there are normal vasculature surrounding the biceps at that level. But we don't see those vessels climb up into the interval. They stop at that little nutrient foramen we talked about last week, right there. See that little divot in the humerus right there? We climb up north, and here we are in the interval, and we shouldn't see any vascular formation around the biceps at this point, not in a normal shoulder. How far distal do we need to go? Kind of a third point to the question. So as I go distal and I see pec major, and I don't have anything that indicates that I need to scan further clinically. So if your clinical exam says that the body of the biceps or even the distal biceps is okay, I would stop here. There's no point in going further than the pec major. So here we are at pec major, inserting on the humerus. We have our long head of the biceps, short head of the biceps. Let's climb up further north. We see the biceps make itself a little bit more known right here. Watch how prone to anisotropy it is. So if you're at the wrong angle, the biceps disappears, the healthy biceps. I say healthy biceps because you can use the angle artifact to your advantage. If you see half of the tendon remains echogenic while you use the anisotropy to your advantage, then you may have an old tendon scar, especially if they have a history of any trauma to the biceps or subluxation. But back up into the rotator cuff interval. It's a good maneuver to practice. So if it's not something that you see a lot in clinic, find you a healthy volunteer or a model and stay up by the acromion level. So here we have that coracoacromial ligament. Find the biceps as far north, staying perpendicular to the humeral head. That's what's most important right there. See the bright white cortex of the humerus, and we have the anechoic cartilage. Then we have the biceps. If your bone is nice and crisp, so will your tendons be. So as long as you're focusing on your bone and they're nice and sharp and not fuzzy like this, you should see a nice bicep sitting in the landmark. If you're just patient is just in a neutral position like this and you go scan the shoulder and you might come across a big rounded part of the shoulder, you're not quite at the groove level. The lateral part of the humerus is rounded. The medial part of the humeral head is a bony peak. That's your lesser tuberosity. If the forearm is bent like this and the palm is up, the forearm kind of chases the biceps groove. So if you keep the handle of your transducer in line with that forearm, you should be in line with the biceps groove. So we externally rotate. Subscap came into view. but also we externally rotated our biceps. So here's the biceps in line with my transducer handle, very nice. And I could even follow those together. And that's really important when we're trying to chase our lateral rotator cuff structures like the supraspinatus. So we internally rotate the supraspinatus a little bit, come up further north so that we're on the greater tuberosity, bring the elbow back, and it can just set right there. And I haven't really moved my probe. I stayed right on the ball shape of the humeral head right there. I hope that answered the question. If it didn't, clarify. It's okay. We're here for you. We have time.
Yeah, that's right. Yeah, anybody else have any other questions? Go ahead and enter them into the Q&A box there. Daniel, are there any other exams where it's helpful to have that kind of side-by-side view?
Yeah, when you're guiding procedures in particular, and you want to stay away from things that are vascular, like if we were doing a biceps tendon sheath injection, right? And you wanted to stay away from those red things that are pulsating and going to cause bleeding into the sheath, which ultimately dump into the joint. And we know red blood cells are toxic to the joint. So we know there's an artery there. If I activate the color feature here, if I'm doing an injection and I'm guiding a needle, the tissue motion can set off the Doppler artifact or the color artifact. But if you activate the side-by-side or the color compare mode, here we've got the simultaneous. I can have the tissue move. In this case, I'm going to rotate the biceps groove towards me a little, like that. And that way we can miss that artery as we slide a needle right over it. And the motion from my needle coming in is not going to set off the motion artifact of the color Doppler. Also, when you're comparing side by side, say I do have a little bit of fluid in the biceps. So let's go back to screen left. Here we go. And we don't have any fluid here, but we're going to pretend that little artery right there is fluid. And maybe it's just normal for that patient. So ultrasound has the benefit of doing a bilateral comparison. So keeping the screen orientated the same way. We do have an effusion over here because our model had surgery last year, about a year ago, on this particular shoulder. And ever since her surgery, she has had a little bit of a halo sign around the biceps because we've got joint disruptions and anchors and cool stuff down in the joint, which could be a whole webinar on its own. But here's the difference in, saying that this patient left side shoulder has a biceps tendon effusion and the right side does not. So in this case, you could freeze that. We could go into our prepackaged MSK labels. I'd go drop down to my shoulder package. Here we go. Text. Got my dry skin today. There we go. Label. Get rid of my arrow maybe. There we go. So left side has the effusion. So we have a left shoulder, biceps, short axis. Add another text over here. Right shoulder, biceps, short axis. Save that picture. 2D. Then we can clear our labels. There, just to be thorough. It's more fun to scan the one with fluid around it. So let's go play around that one for a minute.
We actually have a follow-up to the last question here.
Great.
He says, what is the difference between seeing supraspinatus in the modified Kras position, seeing supraspinatus in the neutral position, and seeing it in the RC interval? Do you need to see all three views of the supraspinatus?
I do the neutral position as a courtesy to the patient, because if in this view right here where I've added the big gel heap like I talked about, big gel heap, I can see where I let my probe up. There's a little rectangle in the skin. I'm going to use a finger under the probe surface and just use that as a stilt. If there's been trauma to this shoulder, I'm looking for volume loss in the rotator cuff already, right here in this view here. So I would freeze it just to point out on the screen what's going on. Yeah, really doesn't like that part there. Okay, so this is the supraspinatus and infraspinatus together. Here's the humeral head. Imagine this is a wheel and this is a tire, and this is a fully inflated tire. So without having to stress the tendon, I can tell if we have any volume loss right away. Also in this position, I can add compression, and I could go ahead and squish down and see if I get the subacromial bursa to herniate in, because when these fibers are not tight, they're going to behave a little bit differently than when they are tight. But if you don't see a huge volume loss, I'm really not suspecting that this modified CRAS is going to hurt our patient, or at least not very much. So it's really just a courtesy to start out with. But once you come out into this view, while the fibers are stretched tight, this is where you're most likely going to see what I would call a flat tire. It's commonly called that at a lot of the programs that you go to, but you would see this wheel look the same, but then we would have this huge divot. This deltoid would herniate into the tendon on its own. If I go long axis here, we can see a beautiful footprint. This is kind of more to the middle facet where it's flat. We go more anterior like that. And it's in this position, and I'm hoping the cameras will pick up this okay, especially when I'm standing just right here. If I suspect there's a rotator cuff tear here, I'll set my hip in front of the patient's elbow, just like this. That's perfect, actually. Okay, and then I have the patient's elbow press against my hip. And in this position, I should see the supraspinatus retract off the greater tuberosity dynamically. And this is really the best view to do that in. So I have them relax. I go check the most anterior portion till I see the biceps. So here's our biceps, intra-articular, slightly lateral here. And then I'll have her do that again. So I just have her press up against my hip with her elbow. And you can see the fibers, they did change their shape a little because they're under a load. And then relax. There. And then maybe one more time as I go through another posterior third of the fibers. Go ahead and push. There you go. And relax. So I do that especially for dynamic study. You're not going to get that very well in the relaxed position like this because a lot of those fibers might be tucked under the acromion depending on your patient and how they're positioned. But here we are. I could have her push against my hand in this instance, and maybe we would get the same level of retraction. Go ahead and relax. But great question. I like to do it for a dynamic stretching of the tendon. It's going to cause more of the abnormalities to show themselves a little bit more defined. But if I can see them already before they put themselves in that painful position, then I like to be courteous to the patient and maybe not torture them as bad.
All right. Well, it looks like we're coming up on the end of our time here. Looks like we've covered all of our questions so far. So just a reminder, we'll be rerunning the third and fourth parts of the shoulder webinar series in January. We'll be seeing you on January 9th for the posterior shoulder and on January 16th for the superior shoulder. And those will be happening at the same time as this webinar. And we'll also be announcing some more webinars soon. So keep an eye on sonosite.com/behind-the-scan webinar for the details on that. Daniel, thanks again for taking the time to put together the original presentation and being here as well for the live Q&A. We appreciate you sharing your expertise, and thank you everybody for joining us today. We look forward to seeing you at the next one.
Thanks, everybody.